Hello, this is a brief video, a simulated video on how to examine an ulcer. In this video, I'll be demonstrating how to examine this foot ulcer, probably a diabetic foot ulcer. Okay, what is an ulcer? An ulcer is a breach in epithelium of a tissue. In this examination, it's assumed I've taken my consent from the patient. I've told the patient what I want to do, and I'm going to be as gentle as possible to limit pain. I will be using a tape measure. I'll be using a cotton board, a cotton swab. In examination of an ulcer, you need to take cognizance of where is the location of the ulcer, the site of the ulcer. For this leg, it's located on the foot, on the dorsolateral part of the foot. You must also know the shape of the ulcer. This ulcer is quite irregular. You have an oval ulcer, a square ulcer, etc. So the site, the shape of the ulcer. Okay. You also, other things you want to know about the ulcer include the surrounding of the ulcer as well. All right. Before we go straight on to the other parts of an ulcer. Before you start examining an ulcer anywhere, as long as the ulcer is on a paired structure or a paired part of the human body, you start examination from the normal leg first. Always go to the normal leg. All right. I have assumed for this examination for the patient to lie this way so I could focus on this ulcer. But in an examination, you have to focus on this ulcer, on this leg first before you come to this ulcer. This examination will be brief and is intended for students, fresh graduates and junior doctors just to refresh on how to examine an ulcer. So the first thing is, assuming I've examined this leg, I come back to this leg and check what kind of ulcer is this. I look at it with my hands gloved, don't touch yet. You inspect the ulcer. You check the surrounding skin with my hands gloved, with your gloved hands. You check the surrounding skin. Then you ask if it's tender, surrounding area is tender. You could check for differential warmth for the patient. You're starting from where the normal to the abnormal, then back to the normal. So you have the surrounding skin if it's warmed. Because if it's warm, you could show that an increased blood flow to that region as well. So it could be an inflammatory process going on. If it's cold, likely there's an impaired supply to that blood supply to that region, and it could be a vascular ulcer you are dealing with. An ulcer could be a specific ulcer, non-specific ulcer. A specific ulcer could be a Buruli ulcer, a syphilitic ulcer, just some ulcers that have been attributed to some characteristic illnesses. In non-specific ulcer, these are ulcers that may not be attributed to any particular disease, such as a traumatic ulcer, vascular ulcers. Those are non-specific ulcers. Other ulcers include malignant ulcers, and these can be benign or malignant. Usually if it's ulcerated, usually malignant ulcers. Okay, so let's go back to this ulcer now. So I have cited where this ulcer is. I have checked the shape of the ulcer. The ulcer appears to be irregular in outline as well. You want to check the size of the ulcer. You will check the size of the ulcer in two planes, the two widest planes. So this ulcer is about 7 centimeters by 5 centimeters. So you found the dimension of the ulcer. In ideal setting, you also go back for the depth of the ulcer. In the depth of an ulcer, you can actually have a caliper, or you have a more rigid measuring tape to check the depth of the ulcer, because ulcers could be quite deep. So all these are still part of the inspection of an ulcer. Then you go on to also check of an ulcer. You also check what is the edge of the ulcer like. Does it have a gentle sloping edge? Which is signifies usually a healing ulcer or a normal healing ulcer. Is it punched out? Punched out means you have a sharp depression from the edge of the ulcer going all the way in. This is classic for syphilitic ulcers, but you can also find it in pressure sores sometimes. Or Is it undermined? For undermining, you may not be able to, you may be able to find the edge of the skin, but the ulcer could have tunneled beneath the skin. And you check that with a cotton swab. You just check the edge. You could see that in some parts, your cotton swab can actually go underneath. If your cotton bud goes underneath, you can know that the ulcer is being undermined. You check crevices in the ulcer. An undermined ulcer, you can also find that as well in pressure sores. Sometimes you can find that in tuberculous ulcers, and that's an undermined edge. You can have a raised and rolled up edge. So the skin comes in normally at the edge of the ulcer, it elevates and stays like a hip. The raised rolled edge, a classic example of that is in the basal cell carcinoma. You can have an ulcer whose edge is elevated, spiking up like that. Edge is elevated and everted like a book outside. So the edge of the ulcer, it goes up and opens out like that. And that is commonly found in malignant ulcers generally. And it shows that there's a rapid growth of cells along the edge of the ulcer, heaping up and spilling out of the edge. A simple example of that is a squamous cell carcinoma. So I've talked about the edges now of the ulcer. So I've talked about the site, size, shape of the ulcer, edge of the ulcer. Then I'm going to talk about the floor and base of ulcer. There's a slight difference between the floor of an ulcer and the base of an ulcer. Now, the floor of an ulcer is what you can see in the ulcer. The base of the ulcer, the base of the ulcer is what you can feel in the ulcer. For example, the floor of an ulcer can be lined by a healthy granulation tissue. It's pink beefy red, or you can find it pale granulation tissue, which is quite, lighter in complexion than a beefy red. Or it can be lined by slough, or it can be lined by discharges, and you have to qualify: is it a serous discharge, is it a sanguineous discharge, is it a serosanguineous discharge, is it a purulent discharge? It could be lined by necrotic tissues or all kinds of things. Right in the floor, you can actually see exposed structures such as tendons, muscles, bone, and etc. within the floor of an ulcer as well. Okay, so you must comment about what is the content of the floor of an ulcer. In the base of an ulcer, with your gloved hand, having taken consent from the patient and confirmed how painful the ulcer is, you now touch the ulcer, taking care to look at the patient's face to check the level of tenderness the ulcer is. Trying to feel how hard is the ulcer. So we've talked about the side shape of the ulcer. We've talked about the edge of the ulcer. We've talked about the floor of the ulcer, and we try to distinguish the difference between the floor and the base. Okay? Now, other things we're going to do about this ulcer now is to find other associations about the ulcer. If it is a diabetic foot ulcer, then you should understand that there are some multiple factors that are involved in the diabetic foot ulcer. The neuropathic component, the vascular component, the inflammatory or the infective component, those three components act in synergy to cause or to aggravate diabetic ulcers. So, I've talked about the floor, and I've talked about the floor is what you can see, the base is what you can feel, and I've talked about the hardness, indurations, fixity. Those are common things you want to confirm about the base of the ulcer. Alright, and when you're done with that, you now go to other things about the ulcer. As you mentioned earlier, what is the nature of the surrounding skin? Are there exfoliations? Is there edema? Is there discoloration or disquamation as well? Those are the things you want to find out. In chronic ulcers, the foot, the surrounding skin could be edematous, could also be inflamed, associated cellulitis as well, and those are the things you want to find out in them as well. Other things you want to find out in these also include, you want to find, are there complications from these ulcers? The complications you want to rule out include osteomyelitis as well. So, other things you want to check the adjoining joint to the ulcer. Can the patient move the joint up and down? You want to see, is it freely mobile? Is the tone okay? Is it fixed? Or you may have a contracture as well, because the patient has not been using that part of the leg. You want to check the sensation. This side where the ulcer is supplied by the sural nerve. So you need your cotton bud at this point in time. You tell the patient to close his or her eyes and you test for sensations before the ulcers and after the ulcers, because you want to understand if there's an associated involvement or erosion of the nerve, or it's actually ab initio that the patient can feel, and that's how the ulcer get there in the first place. All the things you want to feel in this ulcer, you want to check the posterior tibial artery, you want to check the dorsalis pedis artery in this patient as well, the dorsalis pedis artery, the posterior tibial artery, and check if the pulses are adequate or if the pulses are present as well. So as to ascertain if there's a vascular component to these ulcers as well. And the patient with extreme edema of the leg, it may be difficult to palpate that as well in this patient. So you've checked for sensation, you've checked for the vascular supply. All the things you want to check for the lymph node. So you check the lymph node in the popliteal cavity, in the inguinal region, because infection at this level could also manifest as inflammatory enlargement of the lymph nodes at this nearby junctions as well. The last thing you must tell the patient is that you must ascertain the patient's gait and movement. So you tell the patient to come out of the chair or the examination bed and to take a walk. You want to see, is the patient walking normally? Is he or she limping, such as an antalgic gait as well? Or is it just have a high riding, step like that of a horse, an equinus kind of thing, from a contracture of the ankle joint? So, in summary, examination of an ulcer is a common station where you will find an exam, and it's one of the common illnesses, disease, or presentation. The patient will come to you, and you must learn how to examine them well. So you must compare the normal leg with the abnormal site. Check the size of the ulcer, the shape of the ulcer, the size of the ulcer, the surrounding skin around the ulcer. Check for the edge of the ulcer, and I've told you the kind of edge, the floor of the ulcer, the base you can feel of the ulcer. Then you now check all the surrounding things, such as, is there a vascular component? You check the pulses around the ulcer, you check the sensations around the ulcer, you check motions or movement of joints adjoining to that region, you check lymph nodes draining that region of the ulcer, and finally you check the gait of the patient. When you've done all that, then you've examined that ulcer. In advanced states, you might actually do a general examination. You might find peripheral stigmata of certain diseases that can predispose to an ulcer. For example, you could find jaundice and etc. that could show features of sickle cell anemia in this patient and could give an idea of that it is a vascular or a venous ulcer. By the time you check, and you may see other features in keeping with diabetes in the patient, the weight, the glove and stockings appearance, sensations, and etc. in this patient, you may be able to show that this patient has a diabetes or random blood sugar. And once you finish examining an ulcer, you must tell them the ulcer you think it is by saying this is a heart-shaped or a circumferential or whatever kind of ulcer located on the dorsolateral aspect of the left foot, measuring so by so dimension, with an edematous surrounding skin, if inflamed, whatever, positive differential warmth. Just describe the ulcer, whatever you saw, describe it to the examiner.